All, this is Dr. Mobeen Syed from DrBeen.com. Welcome to one more show. So today we have the Dr. Yo. Dr. Yo, who has been trolling everyone when they come on as guests. So today we have him as well. And Dr. Yo was trying to actually stay away from Dr. Bean for some reason. And here we have Dr. Yo. Dr. Yo, welcome.
Thanks, Dr. Bean. It's good to be back on your show, and I'm a little afraid of the people that are going to come at me for payback, all the weeks of trolling that I've done. So please go easy on me.
Yeah, but at the same time, you deserve it now, correct?
I would say, you know what, if you can dish it, you can take it. So you got to be a sport about it. Bring
Excellent.
it on.
Excellent, very good. So let me quickly introduce you and your work. So give me 1 second. So Cool Beans, as you know, this is DrBeen.com. This is the site where Dr. Bruce Patterson and Dr. Yo and their team is working. My disclaimer that I do not have any financial or otherwise relationship with the COVID long haulers or with IncelDx. However, I am grateful that Bruce has been on our show, Dr. Yo has been here, and they bring in information. They have groundbreaking research that we share with the Cool Beans over here. That is my interest, and that I'm grateful for that Dr. Yo and team is here. So Dr. Yo over here, if you see the site, and the links are in the description, Dr. Ram Yogendra, MD, MPH, is a board-certified anesthesiologist with a background in public health and exercise physiology. He received his undergraduate degree in biology at Rollins College in Winter Park, Florida, and his Master of Public Health in Tropical and Communicable Diseases from the University of South Florida. So then he did MD, and then he worked in infectious disease division as well for HIV and AIDS. And the most important thing at this time is that I think in the world, if there is a team of doctors who are leading the COVID long haul, and I would put post-vaccine long haul in the same bucket, this is that team. Dr. Yo, Dr. Purvi, and we are hoping to have her with us soon as well, Dr. Bruce Patterson and their team. So this is their site. Please check it out. This is the thread, Dr. Yo, that for Twitter, that we would have your questions here. This is Dr. Yo's own profile on Twitter. I have the link in the description as well. This is Dr. Yo's YouTube channel, and I have the link for this in the description as well. So with this, once again, Dr. Yo, welcome.
Dr. Bean, always a pleasure. Thank you very much for that wonderful introduction and your support. Even though you obviously don't have any financial or any other relationship with us, I think one of the most important things before we jump into discussion is why you are really integral. Is that one of the things we don't do as physicians is talk to each other. And you having me on the show, Bruce, many other fantastic researchers and physicians, you're making a big difference because we share information. And I learn a lot from you. I learn a lot from Pierre Corey, obviously listening to Bruce and everyone else. We all bring something very different to the table. And then we collectively bring our minds, our clinical experience. So I'm always very grateful for your work. And I think sometimes that, you're an educator for a lot of times, for the students, for the general public, but I think you're playing such a key role for clinicians like myself and the research and work that we're doing. So thank you for everything you're doing.
You are very welcome, and that is very kind of you to include me in the group as well. The work that you and Dr. Patterson and your team is doing is really, really marvelous. I believe that in Nobel Prize for Dr. Patterson, this team, Dr. Pierre Corey, Dr. Paul Marek, Dr. Varun, and that group, Bird Group, I think these groups actually are the leading groups in the world. So with this, let's start our discussion. How about we start with this? So Doug is saying, what is your spirit animal?
I knew this question was going to come, so I got something prepared. It's the horse. This is my spirit animal.
Oh wow!
I knew I was getting trolled with that. I'm the brown horse.
So are you going to keep that on or
I
not?
mean, I could. I think it might be a distraction, though. I mean, I don't know. I don't know.
All right,
People will
perfect.
think, you know what it is? They're going to see this and they're going to say, this guy's not a doctor. What is he? He's just wearing masks and goofing off and putting memes and GIFs on Twitter. So,
Yeah,
but that's my spirit
absolutely.
animal.
I think it is the best way to practice medicine, as you were just mentioning it. So France is saying we got to troll you today. So Dr. Yo or Ram, let's start from the long haul. And there are 2-3 things. So today's discussion, Cool Beans, will continue with the long haul only. So the curiosity that I have is, number one, the IncelDx index, the markers. I hear many times folks say that, hey, we went to Incel or the COVID long haul, the covidlonghaulers.com. We got our markers done. Some of them say, hey, our markers are going down. Great news. Some say we just started. We found the markers. So can you tell us, what are these markers? What do they tell you? And how do they guide management? And how do they tell us about the patient and their situation?
Yeah, thank you. That's a great question, Dr. Bean. So anything in the human body, they're always telegraphing a message. There's always, not just immunologically, but physiologically, so many different aspects of the body. There's always telegraphing a message. As clinicians, our role is to pick up those messages the body is telegraphing and convey that in a way that we can understand that story. So what is taking place with long COVID and the research is pointing to that the last preprint that we just submitted, now it's in peer review and it's been submitted for publication, is that we found that spike 1 or the spike protein of the S1 subunit in those non-classical monocytes, as Dr. Patterson has talked about. And what those monocytes do, a lot of times when I talk to the patients, I say that it's like they're garbage trucks. They're picking up stuff that's not supposed to be there, viruses, bacteria, dead cells. And those garbage trucks have COVID proteins in them. So just like in the twice a week when you put out trash outside your house and the garbage guy comes and takes it, that's how these monocytes work. Now, what's taking place is that for reasons we're not 100% sure about right now, we have some hypothesis about it, but those spike proteins are not getting cleared out of those monocytes. So another way of looking at it is those garbage trucks with garbage inside of it. They are driving all over your body. And what happens when you have garbage with garbage inside of it? That garbage truck is going to smell. It's going to have a stink to it. Because think about it. You've got garbage. Let's say you put garbage for like weeks and months in that truck. It's going to smell. And as it goes all over your body, it's causing a stench. And what we're doing with the IncelKine panel is we're actually picking up the stench. And we're telling a story of where that garbage truck is doing and what it's doing. And like I said, the body is always telegraphing a message. And this is a signal or a way of picking up those signals and telegraphing what's happening. So one of the things in the research is that we suggested there was some vascular inflammation. So why do we say that? Well, one, we know from previous research, especially in HIV, that these non-classical monocytes have an affinity to the blood vessels. And when they go near those blood vessels and they irritate those blood vessels, the garbage trucks send a stench out. The blood vessels send a little stink out. And that's a signal that this story is taking place. They can cross the blood-brain barrier. And then they can put out more signals. They can go into all sorts of tissue and cause these signals. So in essence, what we're doing is all we're doing is picking up signals and telling the story of what's being telegraphed to us and putting it in a way that, one, the most important thing is that our patients understand what is going on. And also, more importantly, the clinicians, because when they look at these panels, a lot of times they just don't understand. Because we're trained sometimes, unfortunately, in clinical medicine to look at solitary values, whether that's solitary lab values or solitary physiological values. Like, for example, if I tell you, Dr. B, that your heart rate is 86, well, what does that mean? What does that mean in relation to your resting heart rate, to your maximum heart rate? Or I say your blood pressure is 156 over 86. You know, if you're going by 120 over 80, you're going to say, oh, then you have high blood pressure. But what if that's your baseline? See, this is what we do in clinical anesthesia, is we don't ever look at solitary values. We look at trends. We look at multiple different values here. And the same thing we're doing here is, you know, you can go to Quest and you can get an IL-2 and you can get an IL-6 and all these random labs, but you need the full panel to tell the story. So it's like having a coloring book and you just have a couple of pages. Yeah, it's not really going to do anything. You need the full book, and that's what the 14 panel does. Why 14? There are hundreds of cytokines there. What Dr. Patterson looked at was these 14 played a key role in acute COVID, and he applied it over to long COVID, and we were able to telegraph the story.
Got it. So the markers in the panel, I'm sure that all of them are important, but what are the markers that tell you that, yeah, this marker is always, we see this most often to be abnormal? What is that marker or set of markers off the top of your head? What comes to your mind?
So when you look at the long hauler index, the equation is interferon gamma plus interleukin 2 divided by CCL4. And there's always questions we get about what do these markers mean. Well, interferon gamma and IL-2 are signs of some pro-inflammatory markers, possibly activation of the pro-inflammatory macrophages. The CCL4 is a T cell recruitment. So what does it all mean? I mean, so this is how I explain it to the patients on telemed. Let's say you or Dr. Bean were on Main Street and First Street, and someone wanted to fight you. And I mean, you don't really look very menacing to me. So you say, look, I'm going to, well, I mean, I'm not saying you're weak, but you're just a very kind looking person. So I don't see you, I don't see you wanting to get into any fights. But let's say someone will getting in your face and say, Dr. Bean, I want your bagel and your coffee for breakfast. I'm going to beat you up. So you send a text message out to me, you send it to Dr. Patterson, you send it to Ahmed, and you send it to Pierre Corey. Now, Dr. Patterson's probably going to come with a bazooka. I'll come with a machete. Ahmed will come with a little pocket knife. And let's say Pierre is going to come with a rifle. So we get this text message from you, and then we say, oh, Dr. Bean's in trouble. We got to go help him out. So here we come, all of us, to come help you out. So this little fight on Main and First Street is now suddenly gotten bigger. And that's what happens in inflammation. The CCR5 receptor, which we talk a lot about, and where RANTES, which is CCL5, CCL4, CCL3, they all work on that receptor. And in the analogy I just used, they are the text messages that you sent to all of us, signaling, I need help. I'm over on Main and First Street. Let's get over here. And I'm sure in a little bit in the discussion, we'll talk about the CCR5 antagonists and how they work. But in essence, that is really what normal inflammation is taking place. In long COVID, what is happening is that there is an impairment of the recruitment of the T cells. So of a recruitment of that signal taking place. And this was in the first paper, where the CCL4 is decreased. So because what most likely I think is happening is because those spike proteins are inside the garbage truck, your immune system and your body is sensing the stench, but they don't know what to do about it because those COVID proteins are inside, sort of evading the immune system. They're not being presented to the adaptive arm of the immune system by those monocytes. So what's happening is there's an impairment then of the full immune response and this persistent elevation of this chronic inflammation taking place. So when you look at that equation, the long hauler index, the denominator is CCL4. So I said, because there's an impairment in the recruitment, because they're probably unable to recognize those COVID proteins, CCL4 levels are not elevated. So that impairment causes those patients now to have this persistent elevation. Hence, because it's the denominator, the long hauler index is going to be elevated. So if you want to talk about specific markers about the long hauler index, that's really kind of like what is taking place here. And what we're seeing is that patients that starting to improve, as their long hauler index is coming down, the CCL4 is coming up. And I'll use another analogy. And this actually happened to me several years ago. I was hiking in Mount Zion in Utah. And this morning we had gotten up, I had a Jeep. Morning I'd gotten up and my Jeep got stuck in on mud. And I kept on redlining my engine, and the wheels just kept on going forward. And what I did was my friends and I put some wooden planks to help get that Jeep over the mud. It's really what's taking place is your body it's revving up. You're redlining your engine because the immune system is recognizing that stench from the garbage trucks, but it's not able to overcome it or really respond to it. And part of the treatment is basically putting wooden planks and rocks under the tire to get the car unstuck out of the mud. And that's really kind of, you'll hear me use a lot of analogies because, all of this stuff is very complex, Dr. Bean. I know your lectures really dive into it. So I always try to explain this to the patients with using these analogies. But those are really what's taking place with the long hauler index. But with that being said, probably one of the things that's very interesting about the markers, in my opinion, is Vegf, VEGF, is vascular endothelial growth factor, and the role of RANTES in this. Because we said that those non-classical monocytes have an affinity to the vascular tissue. So the question is, why is there an affinity? And there's two particular reasons why. One is that we know that endothelial cells, and those are the cells that line your blood vessels, release RANTES. RANTES are the CCL5, it's perfume. It's just sending its text messages, whatever you want to call it. Dr. Patterson likes to call it honey and bees. It's secreted, people think it's just only secreted by T cells and macrophages. It's secreted by platelets. It's secreted by epithelial cells, by endothelial cells. So they're secreted whenever there's some sort of inflammation taking place. So it's playing a very key role here. They're released by vascular tissue. They're released by platelets. They're also released by those non-classical or by those monocytes. Now, the other thing that's important that we're not measuring right now, and it's a little bit difficult, fractalkine. You hear Dr. Patterson talk about fractalkine. I always look at fractalkine as a Velcro. So imagine you have a beach ball covered in Velcro rolling down a hill. And on the one side of the road, there's Velcro on it. And when they both meet, they stick. So RANTES signals those beach balls or those monocytes to come to the sites of inflammation. And what they do is when they come in, they stick to the vascular tissue like Velcro. And when we talk a little bit about the management, I'll talk about some of the medications we're using. But in essence, what happens is then we have the elevations in Vegf, which are released by those monocytes, by RANTES. So that's playing a really key role. The other thing that I think also is playing an interesting role is SCD40L. Not too many people really talk a lot about this, but it's a platelet activator. And there's really a question of what is playing a role with what is causing these activation of these platelets. And I think it's, we can, if you want to talk about the post-vaccine group, I will say this right now. We have a lot of data points now suggesting that SCD40L and RANTES are playing a significant role in these post-vax patients. So we're starting to dive into that group. So,
and is that also because of the monocyte or some other pathology?
Yeah, it's a great question because I don't know 100%. We're still investigating. We spent over the past year really studying long COVID. So we really put all our resources, time into it. I would say in the past 2 or 3 months, we've started to dedicate time and resources into studying post-vax. The interesting thing is we've taken the blood work of 7 long COVID patients and did immune subsets, and all 7 of them have S1 subunits, have most likely the vaccine proteins in them. We want to get 10, so we have 3 more before we can then, Bruce and I will work on the write-up and get that paper out. But the interesting thing is we're seeing the S1 subunits also in the non-classical monocytes. And it's very interesting because in some of those patients, post-vax patients, CCR5 antagonists, more specifically Marabrac, which, by the way, you did a great, I loved your video that you did, the review on it. It is actually playing an interesting role even in post-vaccine patients.
Got it. So if you don't mind, I'm going to dig a little deeper. There are some questions as well, and totally up to you to stop at whichever level you want. Bernard says, what is the mechanism of stench, please? If S1 is inside, how is it detected? So let's have this answer, and then I have another question.
Yeah, that's actually a good question, because you know what, we're still trying to figure out the full mechanism of one. I will say this: the non-classical monocytes they usually have a half-life of 7 to 10 days in the literature, but these are they're not undergoing apoptosis, and the number of those monocytes are increased in these long COVID patients because they are responding. It is, you know, whether it's other signaling that we're not sure about yet, but your body is responding to these cytokines. I mean, there's elevations in IL-6 and IL-2 and interferon gamma and whatnot. Like I said, the long hauler index is looking at interferon gamma and IL-2. So it is recognizing it, it's just not able to respond. It's like those monocytes are sort of signaling in one sense, we've got some garbage here, but your body's unable to respond to that. So that's probably the question of where the stench is coming from. It is recognizing. Plus, they have an increase in the amount of those monocytes, which increase whenever there's inflammation or infection.
Got it. And if I can dig further deeper in this one, you just talked about the lifetime of a monocyte. This has been fascinating for me to think that a monocyte becomes sort of an immortal cell. I shouldn't use the term immortal because it is used for cancers, but a monocyte just starts living on for some more time. Is it a monocyte that continues to live on, or is it that one monocyte with S1 is then eaten up by another monocyte and S1 transfers internally from one monocyte to another? Do you know more about why do they live on, or what really happens that they keep carrying S1?
Yeah, it's something that Dr. Patterson and I have talked about. We think that possibly that there are actually more of those monocytes that are being differentiated, that are sort of out in the peripheral pool, that basically you have more garbage trucks, and they're able to send the COVID proteins to each other. Because the assay, the immune subset assay we're measuring, is looking at the number of monocytes that have the spike protein in them. So we're not quantifying the number of the spike proteins. We're looking at the number of the non-classical monocytes, or really all three, the classical, intermediate, and the non-classical monocytes, seeing the spike proteins in them. So for example, we've got one of our patients from California who has been out on Twitter really talking a lot about her recovery, is her non-classical monocytes, when we first measured them, were 44%. What does that mean? It means 44% of her non-classical monocytes had the spike proteins in them. And then when we decreased, through treatment, we brought it down to 27%. And then the last time was about a week and a half ago, was about 4%. So if we also decrease the number of those non-classical monocytes too. So it's most likely probably what is taking place is that there's a lot more of the non-classical monocytes being made. So, and then they're also swapping those COVID proteins. And there's also obviously phagocytosis, where they might be also, when one of them dies off, another one comes in and eats them up. The interesting thing about the non-classical monocytes is, as Dr. Patterson talked about in your show and also in our paper, was that they express CCR5 fractal kind, but they don't express the ACE2 receptor. So for those the spike proteins from the virus, they're most likely targeting the classical monocytes. They're getting phagocytized by those non-classical monocytes because they do not express ACE2.
I love this mechanism. So for the cool beans, of course, it is clear. And there is a question here as well. So while I put in my comment, Luis Grande has a question for you, Ram. How do monocytes become non-classical? So just a very quick one. Imagine that there is infection or vaccine. There is spike protein, and a monocyte ate it up. And so when it ate it up and it is reacting, that is a classical monocyte. That is a inflammatory monocyte. because it ate up something it didn't like. And so what Ram is saying, and this is so fascinating, is that the repair monocytes, or the garbage truck, or the non-classical monocytes, these are the monocytes whose job is to clean up the area. So they come in and they probably eat up the classical monocytes, which have this little bone in them. And now that bone is transferred to the non-classical, and non-classical ends up with the S1 in it. That is a very interesting idea.
There's one paper that we found, and I have to dig through it. I can send it to you, Dr. B, and I'll post it on Twitter. Is that those monocytes can actually send viral particles to each other, and Maravirac has been shown in HIV, in the HIV studies, to actually prevent those viral particles from being sent. So that's just one proposed mechanism from the HIV studies.
Very interesting. So Luis Grande said, how do monocytes become non-classical?
Well, that's how they're differentiated. When they come from the myeloid progenitor cells, and then they differentiate it. Most of the pool are going to be the classical monocytes. I believe it's like 85%, and the other percentage are going to be intermediate, and they're going to be intermediate and the non-classical.
Got it. I thought that people will be trolling you, but Ram, people are actually appreciating you and loving you. So we got to probably hire folks to come and troll you.
You might have to get Osgood on, or Hyder, just to have those guys get me back.
Got it. So, so we have the non-classical monocytes that have ended up with S1, and now they are releasing cytokines, and that is causing the whole system to become pro-inflammatory. Question for you: how much is known that there is actually an endothelial damage or endothelial inflammation, or is that still a hypothesis?
Yes, we looked at it. I would say it's more of a hypothesis, only because we're basing it on those cytokine markers and obviously patient symptoms, and also how those non-classical, when I say those garbage trucks are crossing the blood-brain barrier, and where they're mobilizing around the body, the affinity to the blood vessels, that's all based on literature and studies from HIV. So the viral reservoir, the non-classical monocytes, they're the garbage trucks on HIV, Zika, other coronaviruses. So it's nothing new where they act as viral reservoirs. So it's like, but we know from those literature, like for example, in HIV, there are tons of papers which show the non-classical monocyte, the CD, so it's CD14 negative, CD16 positive monocytes are crossing the blood-brain barrier. They've been implicated 20, 25 years ago as called HIV dementia and some of the neurodegenerative diseases associated with HIV. So we're using some sort of the literature from how these non-classical monocytes acted, and also looking at the cytokine profile, because what's very suggestive of endothelial irritation is elevations in Vegf, elevations in RANTES, and elevations in SCD40L. So those are the main markers, plus the known literatures where we're coming up with a vascular irritation sort of hypothesis, if you want to call it.
Got it. So Rima joined, and she's asking, you're a spirit animal, so you may have to show that amazing.
Yeah, we got the horse. Here's my spirit animal, and
what is your bean name?
I'm the Dirty Bean, but Dr. Bean insists on me being called the Meme Bean. So I think I'll take the Meme Bean.
Perfect. So you can be once in a while Dirty Bean plus Meme Bean. So before we move towards the management, I want to ask you that if somebody is long hauler, how do they reach out to you? How do they engage with you? What does that process look like? And once again, with the disclaimer that I have no financial or any other interest other than having you and your team here talking with the cool beans. So I'm going to share your site once more. Please tell us if there is a patient, because this is the most common thing that happens to me, that patients reach out to me and say, how do we reach out to Dr. Yo? So here is your site. What is the process for a patient?
Yeah, so it's covidlonghaulers.com. And I will preface this by saying that when we built the program, we wanted to give patients options because, I think it's about what we do in medicine sometimes is we don't empower patients. We don't give them the proper tools and we say it's either this or that. So what we do is we say, you can go in on covidlonghaulers.com and you can get the IncelDx panel. And if you want to telemed with us, it's optional. If you want to take that panel and you want to work with another doctor or another long COVID clinic or somewhere else, and you want to cut us out, we support that. We will help you make those connections. We will talk to your doctors and researchers. We don't have to be part of the telemed. Now, there are two CLIA labs that are running the IncelDx panel. Now, keep in mind, IncelDx is a research diagnostic lab. I do not have a financial relationship yet. Just run that disclaimer. I think over time, Dr. Patterson said I would be part of as a physician consultant, but as of right now, I'm acting as a separate entity. We created a clinical practice where we're doing this, the telemedicine portion, which is completely separate from IncelDx, because we want to keep it optional for patients. So the labs are going to come from Radiance in Chicago and from Los Angeles and Innovative Bioanalysis. They're CLIA labs. And what CLIA means is they're regulated. There's a lot of federal, they're regulated by Medicare. A lot of times patients get confused. It's like these kits are not FDA approved. Well, there are certain laws that give labs like IncelDx and a lot of other researchers in diagnostic labs the ability to use innovation to really get that out there instead of going to the rigorous FDA process. So that's something to keep in mind. A lot of times people get confused. This is FDA validated. They don't have to go through FDA, but they have to get CLIA validated, which is what IncelDx did with the IncelDx panel to get that quickly out there to the general public. So it is federally regulated. It falls under CMS, and they're coming from two labs in Chicago and Los Angeles. Once you put in the requisition and get the request in, you do not need a physician to sign up for the labs. The patient can do that, and that's because the labs, both in Chicago and Los Angeles, have an MD pathologist on board. So then that's how they're able to circumvent those the need for a physician signing off on it. Once you get the labs, the good thing is now the backlogs are over. It's about a week from once you send your blood work in till you get your results. Both labs are running 2 plates of blood work every week. The blood, you'll get the results in a secure patient portal. We do not get it. I think there's always a confusion if Dr. Patterson and I and our clinical team get that. We don't, because we are a completely separate entity. If you want to do a telemedicine consultation with us where we break down the labs and give you some of the treatment recommendations based on our research, again, completely optional, then you can sign up on the website again for a telemedicine, and then we have a patient portal that you set up with us. We don't do necessarily any of the prescribing. We do the treatment recommendations. We do a consultation on what we think could be potentially helpful and beneficial for you, based on your medical history, your allergies, all these other factors in place. And what we do is we will work with your current primary care doctor or your current specialist. We work hand in hand with them. Now, if your doctor is not receptive, or they're skeptical, or they just don't acknowledge that the patient has long COVID or post-vax complications, we've sort of built I call it the network. And these are a group of doctors around the country that we have no financial relationship with, we have no contracts with. They said, look, we understand there's a public health crisis, and we would like to help these patients out. So we will tell a patient that doesn't have a doctor, or whose doctor doesn't want to help them, that's okay. We've got someone in all 50 states that we can link you up with that's going to work with us and be your primary doctor, prescribing, treating, and taking care of you. And what our team does is we sort of help with monitoring and sort of acting as consultants and sort of guiding that process.
Got it. Thank you very much for this. I'm going to ask a couple of questions, and then I want to share something else as well. So France Lorraine says, Dr. Bean, medical lectures, John S. has a great question. are proteins other than spike, like the envelope proteins, being found, I would say, as well? Are you looking for them?
Yeah, I know Dr. Patterson is. We've talked about, the spike protein has two subunits, the S1 and S2. I do know that they are looking for the other proteins. They have not found any as of today. There was one patient that we did find viral RNA 15 or 16 months out, which we described in the paper. We did put some of those monocytes through next-gen sequencing, which we just updated the preprint on the preprint server, the paper, and so the viral components, the RNA that we found, none of it codes for the spike protein, which is suggestive that there is no active replicating virus taking place. That's always a big thing that comes up: is are these spikes? Or is there a replicating virus? I mean, as of today, we have not found anything. In fact, the next-gen sequencing that's been done is suggestive that whatever the viral fragments of the viral RNA doesn't sequence the code for the spike protein. So we're very confident, at least so far from the research, that there is no replicating virus here.
Got it. Anthony says, how does Tylenol and suppressing fever early on impact the likelihood of long COVID? Does fever help destroy COVID early in the infection?
Yeah, it's part of what's called supportive therapy when we talk about the Robitussin and the Tylenol. I haven't seen really any data to suggest that fever suppression due to Tylenol is going to cause any decrease. I mean, they'll cause decrease in symptoms, but the overall pathogenesis, I think it's more of a symptom relief. I have not seen any data to suggest otherwise. In fact, I think if anything, I think we've gotten into this false belief that Tylenol, Robitussin, drinking Gatorade is going to help you get over viral infections. And I think, I personally think once we start really looking into, when all of this hopefully is said and done soon, when we do an assessment on what happened, I think our management of viral infections is really going to change from our clinical experience and the research being done. I'm sure Dr. Bean might I think you might agree with me in some of our discussions that we've had.
Yeah, I think that not only viral pathogen management, but the management of chronic diseases like myeloencephalitis and chronic other diseases would change as well. And I think that the work that Dr. Bruce Patterson and you and the team is doing of finding these monocytes that are abnormal, I believe these markers and these abnormalities will be found for other diseases as well. So you have started a light that I think is going to create a lot of impact. So thank you for doing that. There is a question from Lisa. I'm a part of the research and haven't had my appointment yet. My IL-8 is 300. Can we speak on the long haulers that are having high IL-8?
Yeah, that's an interesting question, and one we get quite a lot. Interleukin-8 is a pro-inflammatory marker. It's released by most likely from those monocytes, and it's very interesting when you look at some of the literature from ME/CFS and fibromyalgia. Interleukin-8 has been known to cause brain fog, known to cause depression and anxiety. So that could be a potential reason why some of the patients are experiencing those symptoms when they have elevations in IL-8, and also with TNF-alpha. TNF-alpha and IL-8 sort of go hand in hand with the brain fog and the neuro issues. Also, it can also cause some fatigue too, because it is a pro-inflammatory marker that's taking place. I think the other thing we should be careful about is, I think there's a tendency sometimes to say, really get cytokine specific in symptoms. There's a lot of overlap that's taking place. Like when we talk about RANTES, it's not only from those monocytes, they're coming from epithelial, platelets, endothelial cells too. So sometimes, and Dr. Bean, you always do these great discussions with the immunology. If immunology, really the human body, if things were very linear, A to B to C to D, it would be really simple. But unfortunately, it goes A to B to C, back to A, then to D, then back to B, then there's an F. And trying to figure out what specifically is what is a little bit of a challenge. And we get these questions all the time about, is this specifically causing this? IL-8, like I said, brain fog can cause fatigue, can even cause some of the myalgia the patients are experiencing.
Got it. So if we can now switch to the management, and I'm going to start with one of the management related question, and then from there we shift to that phase. So the question is, Sandra says, do you recommend vaccines for long haulers, or shall we wait to be more stable?
Ooh, that's a hot button, hot topic. Put me in the hot seat right there, Sandra. So, one of the things with the vaccine is that we do know that a good majority of patients that are getting the vaccines, the long haulers, either it doesn't do anything or they get significantly worse. So it puts us a little bit in a rock and a hard place, because obviously these patients had COVID, they've got symptoms, and some of them are severe and debilitating, and we do not want them to get COVID again. So we do, we're not anti-vax, we're not telling people not to get the vaccine at all. We sort of look at it maybe as two different options. One is get the vaccine, and if you have a bad reaction to it, we can then start treating you. Or hopefully, if you're one of those patients that don't have a reaction to it, then we can wait for 2 weeks and then start treatment. The other option, and which is one that many patients choose, is we say, well, let's get you feeling better. And then let's say 4 to 6 weeks, or in some instances a little bit longer, we will then get the vaccine, because then we know that we can get you better before the vaccine. So it's two options. We leave it to the patient. With the vaccine, things are not very black and white. It's not saying, yes, everyone go take this, take it now. At the same time, we're not telling people don't take it at all. I think to be honest with you, Dr. Bean, it's a personal decision. I think it's a personal decision that a patient has to make with their friends, their family, with their primary doctor. And I think as healthcare workers, we have to be respectful of that. And I quite frankly think that we have really vilified a lot of these people and some of their concerns. And I think we need to be a little bit more sensitive as a society and as medical professionals to some of the concerns of these patients.
Totally agreed. So now let's actually fully dive into the management side. And just for the reference, so that folks don't feel that I am once again just promoting this work, the long haul management, there are other protocols. Actually, there is a protocol that Dr. Yo and I and Dr. Tess Laurie and Dr. Paul Marek and some other doctors, we work together as well, that is available free here on FLCCC's site as well. So this is just to balance out that as much as we are talking with the I think world leaders of the long COVID management, at the same time, here is a protocol where, if you see, based on collaboration led by Dr. Mobeen Syed, Dr. Ram Yogendra, Dr. Bruce Patterson, Dr. Tina Pierce, and so on. So there is a management protocol over here. So with this, Ram, tell me, how is your team approaching the management of long haul?
Yeah, so there's really three things that we're trying to do here. So one is we are working on the mobilization of those macrophages. So what does that mean? Those garbage trucks, they go all over. So they have an affinity for blood vessels. And where are blood vessels? They're all over your body. So one of the things we try to do is we try to prevent, depending on the markers, the mobilization of your macrophages. And we do that with CCR. One of them is the CCR5 antagonist. The one that's available to us right now is Maravrac. And I know we've talked a little bit about leronlimab, the experimental monoclonal antibody, which unfortunately is not available to us for clinical use. And we're only using FDA-approved medications we have now. And this is here's the thing, because there's a lot of experimental drugs. Many different companies are looking at different things because they look at this as this is a big potential market. These very sick patients for the pharmaceutical industry. But my concern as a clinician is getting people better today. I don't really care about some experimental drug or some research that if people are going to take 5 or 10 years. And I sure as hell know my patients don't care about this research and it's this cool drug is going to come out in 3 years. They're all telling me, how can you get me better today? And even if it's 20% better, they'll take it because these people are suffering. I do telemedicine. I think I personally have talked to probably either telemed and doing consultations for the past year with over 1,000 long COVID patients. And so you see how much this is affecting. Use Covert, and what that does is that, remember I said it's when you're using the analogy of First and Main Street, you text all these guys, right? So what Moravirac does is so now you're on First and Main Street, you send a text message to all of us, we don't get it. So now Bruce Patterson doesn't bring his bazooka, I don't bring my rifle or whatever weapon I have. So now you're mitigating that inflammation. Those immune cells are being pulled away or not getting that signal to come and irritate those blood vessels. So that's really one of the first things that we do. Another medication that's kind of very interesting that has some effect on the mobilization is a drug called propranolol, which is a beta blocker. It's a non-selective beta blocker that works on both the beta 1 and the beta 2, which then works on the blood pressure and the heart rate. Why is that important? So here's where there's always a confusion about the exercising. The paper in Exercise Immunology doesn't say that exercise causes the mobilization of those monocytes, or what I call, the garbage trucks leaving the depot and going out, going crazy. I call it garbage trucks gone wild. I think my patients will probably know that. I use that analogy all the time. What triggers the mobilization of those monocytes is epinephrine, also known as adrenaline. And this is why we tell patients exercise up to zone 2. Rule of thumb, what does that mean? Rule of thumb is you break a sweat, you're working out too much. So we're actually developing, in about a few weeks, we're rolling out a physician-led exercise program that's going to address long COVID. And also a dietary medicine program that is led by the director of nutrition at Mount Sinai Hospital, who's going to be leading our long COVID project. So we're getting, I think the important thing to Dr. Bean is that to realize that it's working together in collaboration. This is bigger than Dr. Patterson and I and our team. We've said that from the very get-go. We've identified one piece of this, of what's taking place. So what I'm talking about right now is what I look at this as 2 phases. So we're going to talk about phase 1. I said the mobilization of those monocytes with Moravirac, potentially with propranolol, which can affect the effects of epinephrine, which have been shown in exercise immunology as mobilizing those monocytes. So that's one category. The other one is to use anti-inflammatories and immunomodulators, which Moravirac kind of falls between both that mobilization and immunomodulator. And this is where a drug like ivermectin comes into play, where it acts as an anti-inflammatory and an immunomodulator. And quite frankly, it might be working on the membrane of those monocytes and also in multiple pathways like the NF-κB pathway, which might be inhibited by these spike proteins, which are preventing the apoptosis. And we do know there's some literature suggesting that ivermectin can inhibit the NF-κB pathway and thus causing those monocytes to undergo apoptosis. And that's really the goal here, is to cause those monocytes to undergo apoptosis, causing then the body to recognize those spike proteins. And so that's one particular, that's a second mechanism. And the other one is, we mentioned about fractal time and about that beach ball with the Velcro sticking to the road with a piece of Velcro in it. So imagine this, if I put a piece of paper in between the 2 pieces of Velcro, it won't stick. And that's where the role of statins come in. We found that one of the elevations of the markers was Vegf and RANTES, which are secreted when there's vascular inflammation. So then what is causing those monocytes to stick and cause it? Fractalkine. Non-classical monocytes express fractalkine receptors. Fractalkine is a chemokine. And what's a chemokine? It's a chemotactic cytokine. It's causing all of these things to come in, to attracting it. There's soluble fractalkine and there's membrane fractalkine, which makes it a little bit difficult to measure, because if you've got the membrane fractalkine, how do you measure that, something on the membrane? So it's something that can be a little bit difficult to measure and really get really accurate levels. But what the statins do now is that it blocks, is like putting a little piece of paper, preventing it from sticking. The other medications are pulling those macrophages away from sites of inflammation. And then we're using a different cocktail of medications to lower the inflammation and try to cause these cells to undergo apoptosis. Very interesting. Another medication we use is Prednisone, nothing super exciting. But what it does is that I suspect that the NF-κB pathway, which is affected by glucocorticoids, might be playing a role here. But again, it's purely hypothesis. That's what I call phase 2. Well, sorry, phase 1 of the treatment. So what is phase 1? Phase 1 is if you have a forest fire, we got to put the fire out. Phase 2 is then we got to regrow the forest. And that's where I look at the role, really the significant role of the antihistamines, the NAC, the glutathione, the supplements, eating well, exercising properly, graduated. These patients have a level of deconditioning the last 12 to 18 months. So what we've done is really focused on phase 1, the immunological phase, putting out the fire at the source, not treating symptoms, but at the source. But the forest is still burnt down. And this is why when you look at some of these patients, immunologically, they're doing well. When you look at their number of COVID proteins, they're going down, which, by the way, I will say this end of August, the immune subset panels will be run through Chicago and LA. It'll be open up to it'll be commercialized through the CLIA labs, which I believe is going to be a key game changer in our management of long COVID, because now we have a second metric along with the cytokine panels. We're going to be able to measure your response to therapy using also those COVID proteins. But phase 2, I think sometimes when I'm looking at the management and what some other clinicians are trying to do in some long COVID clinics, they're trying to rebuild a forest while the fire is taking place and not really getting anywhere. And that's the one thing that I'm trying to tell other clinicians, put the fire out. And so phase 2 is then we start talking about the niacin. I know the niacin guy has been threatening us, Dr. B. Maybe you should have him on your show. But that's where a lot of those other things come to play. And I don't want to discount it. I think there's definitely a role there. But like anything in clinical medicine, you have to know where in the pathology you are and treat the patient accordingly.
Absolutely. And my own experience, before knowing all of these mechanisms, especially the S1, last year, when I started seeing the long haulers, my instinctive way to manage was something you just said, that put the fire out. So I started using steroids and ivermectin, and that had magical results. And then, of course, Maraviroc, and I have not used Maraviroc though, fluvoxamine, and then MCAS, and then mast cell activation syndrome issues. So very good. Tell me this, are you ready to go over some questions now? I'm
afraid, but go right ahead. Hopefully they're not the troll variety.
So I'm going to do this. I'm going to combine questions here on YouTube and the questions that are already on Twitter. So let's do that. So I'm going to take a few questions from Twitter, and then I'll go back to the live questions. So here, Avok says, dear doctor, your team's CD16 monocyte paper is work of art. Thank you. Do you think anything can be learned by observing lupus and arthritis patients who also get long haulers because of the similar increase in intermediate CD14 plus CD16 across those diseases?
The pathology between them are going to be different. I mean, we're talking about really autoimmune driven diseases. But I will say this. Our research in long COVID is really, as we sort of touched upon, Dr. Bean, is going to open doors. And not only just this research with the monocytes, but our framework is how do we approach the post-Lyme, these post-viral, these chronic inflammatory diseases, these chronic diseases that have befuddled clinicians for the past 2-3 generations, because we're using outdated ways of approaching clinical medicine. We take this one size fits all, and we know this, and we've learned this when we were little kids. The cliche, everyone is unique and different. Why don't we do that in clinical medicine? Why are we still trying to say that you and me and everyone else, we're all the same and we got to get the same medications and same dose? Everyone's looking for a magic pill. So I think what we're doing is really revolutionizing the way we approach not long COVID, not post-vax, clinical medicine, using precision medicine. It's the sexy term, precision medicine. Well, what are you using? What's precise? What are you measuring? It's saying everyone goes, well, we want to measure DNA and we want to measure genetic stuff, but doing it in a scalable way where we can do this and affordable to get this out to so many people. So I think more than the science and more than what we're learning, it's the approach. It's how do we systematically approach this and what do we need to do? And case in point, the post-vax group, we knew how to study them, because we had this method already that we had refined and continuing to refine the study methodology. And within 2 months, we started getting data points, doing analysis, and understanding how to treat these patients. So, we are sort of a beta testing all of this. That's I always joke with Bruce and others that we're beta testing a concept. So to answer that question, even though the pathology is a little bit different, they're autoimmune disease, the approach can be used with trying to find a commonality or a common signature, and really then trying to target specific markers for these other pathologies.
Got it. Thank you very much. Mr. Wines says, what are his current go-to drugs and nutraceuticals for Delta variant infected individuals presenting early? What is his success with regards to hospitalization and long haul vis-a-vis Delta? Thanks.
Yeah, I think the Delta variant is a little too early right now to really make any comments on what the prevalence of long COVID is going to, how it's manifesting. But I will say there's sort of, when you look at the different variants, looking at mechanisms, I think the same medications we've been talking about, the ivermectins, the fluvoxamines, are playing a really key role here, where there would be less sort of effectiveness on maybe some of those monoclonal antibodies like the BAMLAB, the Regeneron's antibodies, which were more specific to the spike proteins. They may not be effective, and I've always been very skeptical about the use of remdesivir in general. But for me, nothing in terms of the mechanism really changes in terms of the ivermectin versus the fluvoxamine.
Got it. 2 more questions from here, then I'll go to YouTube for a second. So it's CDDO says, can post-vax reaction cause low hemoglobin, other symptom unrelenting spinal and back pain, insomnia, nausea, visual disturbance, floaters, weight loss, anxiety, brain fog, confusion? Numbness in hands and face started 2 weeks post second vax, 74-year-old. So once again, we can't give a specific advice, but the basic question here, can the hemoglobin level be reduced because of vaccine?
Yeah, I haven't personally seen that yet. I think there is a concern that the spike proteins might be in the bloodstream and causing microclots and endothelial damage. And our mechanism is more the monocytes are, and we have the evidence, we have the proof to suggest that that's what's causing it. So I haven't seen necessarily a drop in hemoglobin, but I will say this in terms of the clinical presentation. The patients with the post-vaccine group they're tending to have more neurological symptoms than the long COVID patients, or seem to be more vascular in nature. Now, there's some overlap in terms of the symptomatology, But I've had some patients that are having tremors on the telemedicine. So, as a clinician, you can tell. We just have these, these instincts that we develop in clinical practice. We know when someone is sick, which you and I, Dr. Bean, we know it's the color of their skin, their eyes, their mucous membranes, just that overall appearance. And some of these post-vax patients are in definitely in rough shape. And I think that's probably more neurological in nature. And we're still trying to investigate what the, sort of the pathogenesis behind that is.
Got it. Thank you very much. One more comment question from here, then I'll go to YouTube. So Avox says, so this is not a question. Dr. Patterson and Yogendra report they are using machine learning approach to analyze their highly complex data, but I think it's really Mobeen in here. Okay, so let's play Mobeen here. All right. Okay, cool. So I think even if you know that it is me behind there, don't tell anyone. I'm going to ask some questions from here. Texas Meg says, Dr. Bean Medical Lectures, does the sound of Velcro make Dr. Yo's little brown pony buck? What do you think?
Sometimes. But that's why I give my little brown pony a statin so that it doesn't make the Velcro noise. Remember I said he put a little piece of paper in there? That's how I put him to sleep.
Got it. Sarosh says, have you looked into Effexor? I read that it is in the lower, it lowers Rantes, IL-12 and interferon gamma in rodents.
No, we have not. I think we have to be very careful when we start looking at some of these anti-psych medications, anti-anxiety, antidepressants, and the neurochemicals. There's a lot of drug-drug interactions. There's a lot of the neurochemistry that we don't want to disrupt. And yes, one of the things is a lot of different medications can lower cytokines. So, even though we are taking kind of an experimental approach with FDA-approved medications, it doesn't necessarily mean we have to go reckless and start testing things out on people. There has to be some sort of scientific justification behind it. So I'm very cautious, and we've got a lot of patients that are on other SSRIs and some on TCAs like nortriptyline and amitriptyline. And quite frankly, we do not mess with any of those dosing. We don't tweak anything. And a lot of those patients, we don't even put them on fluvoxamine, or if we do suggest it, we really talk to that primary care doctor. So to answer that question, no, we have not. But if we get some literature or some trials that suggest that, we would definitely be open to it.
Got it. Kathleen says, criteria for long haulers diagnosis are their lab values, ? Or just fatigue and malaise, tinnitus, is it intermittent aches, how long after COVID to diagnose as long COVID?
I'm not exactly sure the question. What is the criteria?
So let me break them down. So first of all, when do you start calling it long COVID? Is it 2 weeks after if the patient still has symptoms after recovery, 2 months after, 1 year after? What is long COVID's definition?
Great. Yeah, that's an interesting thing, and I think this is where this is why the whole research behind long COVID is we still have a consensus on the name. I mean, is it long COVID? Is it chronic COVID? Is it acute or PASC? We've got all sorts of terms being thrown out at times. I'm trying to hashtag something. I'm like long COVID, long haulers, PASC. Then the truckers come and get all pissed off at me because I'm using long haulers and their claim to it. So the British Medical Journal put out a report about end of last year, which I like, where they're calling sort of that long COVID as between after 2 weeks, symptoms after 2 weeks to 12 weeks, and then after 12 weeks onwards, any symptoms they're calling it chronic COVID. I sort of like that because. Here's the question is, if you get over an acute COVID infection, how soon after your infection do you start treating your symptoms, these brain fog? There's numbers of patients that recovered and they got better after maybe 2-3 weeks after their initial infection without any medication. And I come from the school of thought that the less medications we give to someone, the better. Polypharmacy is not something I advocate for. I'm very, very conservative in my clinical management. So if I can avoid giving you medication, that's going to be my goal. So the way I look at it is I usually wait till you're about maybe 4 to 6 weeks after an infection, and seeing if you're still having symptoms before I personally feel comfortable treating, because I like to give a little bit of time without medication and really supportive therapy to see if you can sort of get over the hump on your own.
Got it. A couple of more questions here. One is that, so if I can collate these two parts of the questions together, is the long hauler definition based on clinical signs and symptoms or labs, or I would add one more, or it is a combination of both?
It's definitely the combination of both. You know, if we based everything on lab values, we wouldn't need clinicians. We just all, you know, put in things through a artificial intelligence or machine learning, and it'll spit out the medication. The human body is extremely complex, where labs and immunology is just one piece of that puzzle. The full spectrum this is where our clinical judgment comes in. So we align both the labs and the symptoms. And there are some patients that actually, and many of them might attest to it, they get the lab work done. Their long hauler indexes suggested that they are a long hauler. So anyone above 0.71 on the index is, according to the algorithm, is considered a long hauler. But there's no lab, there's nothing elevated in it. And they tell me, what is the meaning behind this? Why am I considered a long hauler, but nothing is elevated? And I tell them, well, one, if you have the signature, it's a fingerprint that suggests that your immunology responds in a way that suggested that this is due to some viral particle from COVID. And you know, I think that we can then align them with the symptoms. And then the patient's like, well, I have brain fog and I have this and this. And in some ways we are treating symptoms, but we're also treating the underlying cause from due to the lab results. So they definitely go hand in hand.
Got it. Got it. Thank you. One more question here, then I'm going to switch to Twitter. I'm so sorry for doing this to you, but as many questions as we can get about long haulers, especially from you, who's actually you and your team leading this area, that is the benefit, that is the advantage we have. So I want to take advantage of your time. So my apologies for continuing hammering these questions. So Rima says, is a high VEGF a key indicator?
It's a big marker for us, because Vegf is a sign of some sort of vascular irritation, and we do see that very elevated in patients. Now the research is really showing that about 80% of patients in our cohort, which we now have over 5,500 patients registered in our program. What's the data that's suggested right now is that about 80% of patients with brain fog and neuropathy have elevated in Vegf. And I think Dr. Patterson's really talked about that in some of his discussions. So it is a key marker. The paper that was out in Frontiers, the first paper, when we did a deep dive into the machine learning during the peer review process, the role of Vegf really started to manifest itself, which is kind of interesting because we were also seeing that sort of on the clinical side too.
Got it. Thank you. Jody says, what percentage of long COVID versus long haul because of vax have dysregulated lab results? Are the results similar?
Well, you know, the interesting thing is, yeah, you know, most of them do have, you know, we are able to pick up different signals. Either they register in a long hauler index or their markers are just all over the place. We definitely, you know, will have 1 or 2 markers elevated at a minimum. And so that's, you know, we do see a lot of there's definitely inflammation taking place. Now, there are differences between both groups. And like I said, we're still trying to investigate. So I don't want to make anything sort of conclusive statements. But what is very clear, the picture that's coming to us with the post-vax group, is that Vegf is not elevated at all. There might be maybe 2 or 3 patients out of, you know, maybe 60 or 70 that I've really looked at personally myself that have elevations in Vegf. Most of them have normal Vegf levels. So, but which is, you know, kind of interesting. That's why I said earlier, and also the clinical presentation is more neurological. You hear a lot of the tinnitus, the brain fog, the neuropathies, the tremors. The tremors are, you know, that's really shocking as a clinician when you see previously healthy 30-year-olds they're shaking uncontrollably on telemedicine, it's really shocking. And these are high functioning people. These are not hypochondriacs or people making things up. They're attorneys and doctors and business people and moms and dads. And I don't think they're going to be, shaking for the sake of it. And they just want to hold their kids again. They just want to go back to work. So I think we owe it to study this group. And when we start talking about the vaccine, I think it can be very controversial. People are scared. They're worried about being named an anti-vaxxer or you're anti-vaxxer, pro-vax. Here's the thing. We just want to study. We want to know what is going on and help those people that are injured. That's all it is. We're not taking a stance on anything. And we're not asking to shut anything down or the programs down. We just want to help these people. And I think this is another big public health crisis after long COVID. I feel like we're repeating history again. A year ago, Bruce and I were screaming on top of our lungs, on top of that mountain, and we're doing the same thing again. And we're looking for resources and help, but so far we haven't gotten anything.
Got it. Thank you. So Colin Hamill says, is Dr. Yo a relative, as he's so clear at explaining things like you do too, Dr. Bean? What do you think?
We are not related. We're not related. I'm just a dirty bean. He's the king bean.
So we are, of course. So Dr. Yo is a friend of Dr. Ahmad Zafran. Dr. Ahmad Zafran was medical director for Dr. Bean for our first 3 years. I believe Dr. Yo and Dr. Zafran were class fellows in St. George.
Yeah, we went, he was my anatomy friend, literally first day, because his last name was Zafran, mine's Yogendra, so we got paired up alphabetical. And we've been very close friends, and very interestingly, we both did anesthesia together. He did his training at the University of Texas, and I did my training at SUNY Downstate in Brooklyn. But our paths crossed again during oral board studying, and we both took our exam in Phoenix, Arizona, but several years ago. So, yeah, we've got a mutual friend, Dr. Bean and I. So.
And you both are brilliant. So you are here talking about long haulers and the groundbreaking work that you guys are doing. And Dr. Ahmad Zafran, in addition to his work, he has founded a company as well called Lucid Lanes that is taking care of the narcotic wave that is going on and the patients there. So he's very successful as well. So JLB says, could vaccine increase pathologies that person already have? Example, gout, kidney insufficiency, water in lungs, etc. Could vaccine poke other issues?
I think we have to be really careful to really jump to any conclusions right now. And of course, I know some people are going to be disappointed in that answer but as clinicians and researchers, we can't jump to conclusions. We need more evidence. But we can start looking into things and seeing some correlation. The interesting thing is the research is suggesting that a small group of patients are having I don't want to say small group. I don't think we quite know the epidemiology behind the post-vax complications. I'm going to leave that out there because I think the VAERS is underreporting. I think people are afraid. I think doctors are afraid of speaking up. I think also people are just blowing it up there. They just don't want to be labeled an anti-vaxxer. But here's the interesting thing, Dr. B. If these patients that got the vaccine and had complications are anti-vaxxers, why the hell did they get the vaccine in the first place? They're not anti-vaxxers. They got the vaccine. They're not saying no to it. And a lot of them said they would, they still would consider getting the vaccine because they don't want to get a COVID infection. Because, I know there's sometimes this discussion about, well, there's ivermectin that I can take. It is getting more and more difficult getting ivermectin. One of our patients today just texted me saying that the pharmacist refused to prescribe the ivermectin that her doctor had written for her or dispensed the prescription. I talked to Pierre. Pierre and I have just gotten into heated conversations about this. So it's not as easy as saying, okay, take the ivermectin. No, it's getting more and more difficult. If you get hospitalized, your chances of getting these medications are almost zero. So that's why, it's really important that we look into these vaccines and really study it and try to understand what is going on. I also think it's a little bit disingenuous for any healthcare professional to tell these patients, take it, it's safe. And the evidence suggested it's safe and you should do it. No, we should be honest with the people. We should say, look, so far it's suggestive that it's safe, but there's a lot we don't know. There's the whole issue with informed consent. We have to be open with people. And I made the argument that I used to work in the health department in Florida. I have an MPH. Transparency with the general public is important. We have to tell them. People are not stupid. We're not a bunch of sheep, Dr. Bean. But if you tell people, look, this is what it is. These are the risks. These are the benefits. I feel like you would be much more impactful for the vaccine hesitancy and really keeping that transparency and the trust with our health officials. And unfortunately, I think that's a big, that's really been detrimental. Now, I will say one thing about the vaccine. I know we don't want to talk too much about it, but the COVID protein, the S1 subunit that we found, what I wanted to do now for the paper was to look at people that got vaccinated and have no symptoms. And here's the interesting thing we just found out last Friday. Some of them have S1 spike proteins in them 5 months after the vaccine, no symptoms. So
that's very interesting.
It's a very small number, so we can't make any conclusions. People can't be up in arms about this. It does warrant further investigation. What I'm now doing is this week is getting blood work into IncelDx that's going to have patients that never had the vaccine and never had COVID, and let's look at their blood work. In the paper, the preprint we just put out, there are 10 healthy controls. So we do know that the spike protein should not be in these patients because we did have 10 samples. So we're looking into that, but I don't want to startle anyone, but they might get startled. Pierre is startled. I'll tell you that. He's all over. I texted him that today, and he's all scared about that.
Yeah. And one way I think that these folks who are not letting or not encouraging vaccine-related side effects in their discussions and wisdom of the decision-making, they are banking on people fighting with each other. It is actually serving the people who are trying to keep the eyes closed. I think from a medical point of view, we should look at where are the side effects and what are the benefits, and we should make them clear. Just putting a label out there is not sufficient. What will a patient, how would they make a decision? Let's say I want to have a vaccine. You put the label that, well, this can cause clotting. So what do I do? Be more scared and still go get the vaccine? If there was a wise way of saying, here is an algorithm, if your age is this, if your comorbidity is this, here is a kind of vaccine that is going to give you the least trouble. Here's a kind of vaccine that is going to be the best for you, and so on. That is not there. Then a protocol to say, once you have the vaccine, if you are in this risk factor, then here are the tests and follow-ups to do. I think that all is not happening. And we, people, becoming those groups, fighting with each other, calling names to each other, calling quacks to each other, are actually allowing these folks who are responsible to make these algorithms and protocols to get away without any accountability. Anyways, I'll continue to rant, so I'll stop. Bill Beer says, friends.
And then Dr. Bean, I just wanted to interrupt just a quick sec along those lines. There are other vaccine platforms that are coming. And the one interesting thing, I was talking to Dr. Osgood today about this, and it's also an observation that I saw, and we were sharing this together. A lot of these patients that are hesitant about these mRNA vaccines, a good majority of them, and this is just purely anecdotal, they're all waiting for the Novavax vaccine. So they're not saying no to it. They're just saying they have concerns over this. And there are other vaccine platforms that are out there. Tonics, it's got a horsepox, there's a peptide, there's a bunch of different platforms.
There's nasal vaccines, there are GIT-based vaccines, oral vaccines, correct. So there are lots of other options, and these should be looked at. Absolutely correct. So Bill Beers says, friends keep assuming that the messenger RNA from Pfizer and Moderna will get into our DNA. They don't understand that it cannot get into the nucleus. What's the best way to settle this, or is it pointless?
I'll just tell them to go to drbean.com and listen to your lectures, because I just don't have the bandwidth or the time to have arguments with stuff that doesn't make any sense.
I like your answer. Bill Beer says, a UK doctor, Philips von Walbergen, has posted blood smear pictures before left and after right. Vaccine shows damaged RBCs and other oddities in the after image. Is this real or to be expected?
I have not seen that. I have no comment on that.
Yeah, me neither. Paula says, question, Dr. Yo, what are your thoughts about peptide T as an alternative when Maraviroc unavailable? Peptide T is a CCR5 inhibitor that I have found beneficial.
Yeah, that's interesting. I wonder where Paula found peptide T, because it is unavailable to the rest of the world. At least Maraviroc is available. It's clinically available. As far as I'm aware, I know peptide T. It was studied in HIV back in the 90s, and I don't think it was ever approved in any country.
Got it. Harry Mensch says, is there a link between post-COVID small fiber neuropathy, vascular inflammation, and dysautonomia in long COVID?
Yeah, it's all connected. It's all VEGF. The Vegf is causing vascular irritation. And here's the interesting thing. Sympathetic nerve fibers, blood vessels travel with sympathetic nerve fibers. We learned this in medical school, in anatomy and in physiology. So when you irritate those blood vessels, and blood vessels that also supply the sympathetic nervous system, you're going to have autonomic dysfunction and dysautonomia. So, we are seeing patients that are improving on our protocol. Their dysautonomia, the POTS are getting better. Their neuropathy, the use of what Maraviroc does, it targets RANTES and has a downstream effect on Vegf, IL-8, and IL-6. So it's causing, really helping with the neuropathy too. So the connection there, Harry, would be Vegf, VEGF.
Got it. Thank you. TL Holo says, have they treated a long hauler who was experiencing breathing issues? What did they find to be the problem?
Yes. This is the thing I would say, statins. When we think of shortness of breath and breathing issues, initially we're thinking the structural damage. There's some sort of smooth muscle irritation or some airway irritation taking place. We put these patients on albuterol, budesonide. And look, I think maybe about 10 or 15 patients do respond because there is a reactive airway component here. But, what was very interesting is once we added statins to the algorithm, the number of patients that came back to Dr. Patterson and I and said, our shortness of breath got better. It was just, it was pretty remarkable. I mean, who would have thought a statin, a medication to treat cholesterol, would help with the lung, with some of the respiratory issues? But we're seeing statins to be pretty dramatic.
Got it. I'm going to switch to YouTube for a few more minutes. Can I take some more time? 5 minutes, 10 minutes?
Sure. There might be a Bruce Patterson troll. I don't know if it's a real Bruce or if it's a troll Bruce, but there's a Bruce somewhere floating around here, Bruce Patterson. So I just wanted to kind of got me distracted there for a moment.
Okay, let's see if I can find him.
You know what? You should ask him about RANTES and then see if
then we'll know. He'll immediately
ask him about his boat. Yeah, he'll immediately get all excited and show himself.
So Bruce Patterson, is this about RANTES or do you even know about RANTES? So that would tell us if he is really Bruce or not.
Right, exactly. He will know. Oh, he says it's the real. How do we? Well, here's the thing, Dr.
How do we know?
How do we know it's the real Bruce?
Yeah. I mean, what is real? Real could be anything.
Yeah, real could be anything. Show yourself, Dr. Patterson.
Yeah. Or tell us a secret that only Ram knows. Ram, do you have secrets with Bruce that only you know?
No, not. We're not that close. I don't think I want to be that close. I'm just kidding.
Okay. Ram is giving a disclaimer very quickly. No, not that close.
Yeah.
All right. So let me continue to ask some more questions. So Ram, you go hands up whenever you feel that, hey, I'm out of time. Meanwhile, Bruce, please troll away because he doesn't deserve any mercy. He has trolled you a lot. So MSNBC says, if TIA with statin, would a person be more at risk for ivermectin crossing blood-brain barrier?
Yeah, it's a good question. There's always a concern, with the leaky brain or the leaky blood-brain barrier, and people are worried about ivermectin. It really depends on the degree of the stroke and what are the symptoms. I would feel pretty comfortable, sort of the compromising of the blood-brain barrier due to a stroke would be, and especially with the dosing we're using with the ivermectin, it's not something that I would be overly concerned. I think there has been literature that suggests that it's more of a dose response at very high doses. You can see some of the neurotoxicity and some of the seizure issue. And if the dosing from the FLCC and what we are using is, we are really talking about extremely, extremely low doses here. So I don't think it should be a major issue. But with that being said, part of clinical medicine is taking those things into consideration. It's not saying no at all, but seeing the degree of the stroke, what medications they're on, any symptoms from the stroke, any sequelae from it, any neuro weakness, and then making that assessment.
Got it. Michael says, a friend is being treated for a small but aggressive brain tumor. Which vaccine best, mRNA or adenovirus?
You know what?
Or lufimectin, which is ivermectin.
I would, it's tough. What exactly is the best? One can make an argument that maybe the mRNA and the DNA platforms potentially might have some long-term issues with that. The interesting thing is the Sinovac or the Sinopharm vaccine uses the weakened or the dead virus in there, so they use a different platform. I'm not saying you go to China or one of the countries to get vaccines, but the point I made earlier was, but there are multiple different platforms. So if you're not comfortable with the mRNA and DNA platforms, I do believe that in Q3 of 2021, Novavax should get the next EUA, and that could be something that people want to hold off to, and consider Novavax.
Got it. Texas Meg says, Dr. Yo leave his bazooka on his little brown pony when he goes out to fight the zombie monocyte cannibal cabal?
No, I got to take it with me because you need the bazooka to knock the garbage out of the garbage trucks. I always have it next to me.
I see. So you are actually playing with bazooka. So here we have Bruce. We are launching a nutrition program. Is that a secret that only you two know? Yeah,
that's the real Bruce.
You actually talked about it as well.
Yeah, we did mention that today. Yep. We're launching the nutrition exercise program in the next couple of weeks. And here's the really exciting thing, Dr. Bean. You have a lot of the patients from the EU and in Spain. We're launching Spain the first week of August. We have 2 Spanish doctors that are joining us, Spanish-speaking doctors, to do the telemed. And then the rest of the EU opens up in the first week of September. So we are scaling up. Dr. Patterson and the Magic Bus are coming to Europe. And finally, it's been over a year. These patients have been really asking us about this, but we do things the right way. There's a lot of regulatory, legal things, and we checked off all the boxes, and we're putting this all together. So awesome. the nutrition program, a lot of times patients just always say, well, you guys only talking about Maravec and ivermectin. There's nothing else. And no, we understand. Dr. Patterson's a physician. I'm a physician. All of us, we understand clinical medicine. We're trying to put together know when to treat these patients appropriately. Put the fire out, get rid of the forest fire, regrow the trees in the forest, and send these patients, smooth sailing.
Absolutely. So this actually proves that we have Bruce over here.
Yes, it is Bruce. Yeah, and he's now talking about the magic double-decker bus.
So let's
totally
see.
Bruce Patterson. You know something, Dr. Bean, we people always look at Bruce and they see like this serious scientist, and he's just a fun guy to talk to. I mean, we just have a great time. Our team's amazing. It's just really smart people that came together and really put all our clinical insight. And of course, it's backed by Bruce's research and all the work he's done. And one of the things we talk a lot about in medicine is translational medicine. If you look at some of the studies that are being done right now in long COVID, there are these longitudinal studies and these epidemiological studies, and people want to do breakdowns of gender and sex and demographics. And here's the thing. It's important. I come from a public health world, a public health background. We do need to understand those demographics and the socioeconomics. But as clinicians, I don't give a rat's ass if you're black or white or man or woman or what a gender you are or what part of the world you live in. I just want to get you better. And I think we need more resources and more studies going into the actual science. And I don't know really anyone except, Bruce and our team that's really doing that. Of course, there are the studies and things out there, but it's a translational medicine. It's how do you take the research and make it into clinically actionable plans today? And I challenge anyone to find anyone else in the world that's doing what we're doing besides us and you, Dr. Bean, and the FLCC guys, doctors like Corey and Tess and Tina and their team. We're all trying to get people better today. We're researching, we're testing, we're studying, and we're treating today. And you know what? Maybe a week from now, or 2 weeks from now, or 3 months from now, maybe our approach changes. And things are constantly changing, and we're adding new things to the algorithm. We're understanding the medications and response. But that's the key thing that we're doing that differentiates us from everyone else.
Got it. So Dr. Bruce Patterson says, how do I become a cool bean? So Ram, do you have
he's just on the troll train today. He's really getting to me today. I mean, wow, this is the revenge of Bruce Patterson. I knew I had a feeling that he was. I don't know what was Bruce's name. What was his name? What was his bean name?
So we can decide some name. For example, researcher bean, or from long haul, maybe long string bean.
It should just be Ranty's bean.
Yeah, I think that is nice. So Bruce, what do you think? Ranty's bean? Bruce is gonna have nightmares with Ranty's at some point.
Well, that's the name of his yacht or his boat that he goes sailing in.
So then maybe Ranty's bean is a good name.
I think, or someone just said Rant Bean.
Right. So we have a question. Jessica Milton has an important question concerning a non-diabetic person who's had AZ jab and developed leg ulcers. He's been on ivermectin with no improvement. How to treat? I think here is the question. So there is a question about somebody with after AstraZeneca having a leg ulcer. What is the way to treat?
So here's the thing. We can't automatically assume it's due to a vaccine. So we still have to go through the clinical pathways. It's it's the same thing with long COVID. We can't just assume everything is long COVID. So first thing we have to understand is, what is the history behind it? Perhaps doing some imaging studies, a Doppler studies, looking at doing physical examination, seeing there's some sort of underlying condition there. If we sort of eliminate everything else and we suggest, okay, it's possibly due to the vaccine, I would say COVIDlonghaulers.com, not because I'm trying to promote ourselves and if you're not responding to the ivermectin, but we want to see if it is due to the vaccine, what sort of markers are elevated, and really then do targeted approach. And like I said, ivermectin is just one. I mean, it is a very important tool in our toolbox, but we have an armamentarium of different medications and combinations that we're using, and quite frankly, very successfully on a lot of these patients. And we're getting more and more post-vax patients starting to feel better. I would say this: there are definitely some long haulers and post-vax patients that are not responding to the treatment, but quite frankly, I love them because it makes us all think. And by understanding the really tough patients, it makes us really dig into the weeds and understand the pathology. Then we can really get a good handle on it. Maybe, it's good to say, hey, look, we have 100% success rate and it feels good, but there's no challenge there. We really want to understand what is going on. So I welcome the challenge of the challenging cases.
Got it. So Jessica, I usually avoid questions which are directed, or the answer could be directed towards a single person. So I would avoid that question, but once again, please talk with your doctor as well. if you like, you can talk with Dr. Yours or Dr. Patterson's these clinical labs to. Again, I have no relationship or interest in these. I think they have done something that is groundbreaking for the whole world, not just for the US or a city or a town. And whoever can take advantage of it should. But that is my opinion as a doctor, not an advice. So please, as Dr. Yo said, that is the answer. Bruce Patterson says, how about RBean? I like RBean. Do you know why? It covers researcher bean, and it covers ranties as well, and it covers rant as well.
Yeah, let's call him. I like that. RBean.
RBean, done. So Bruce, we got RBean.
Well, what about Dr. Bean? What about calling him Bruce? I do not write notes for my patients. Bean Patterson. I'm trying to get him to write his patients. Bruce, can you do your notes for your patients? I know all the patients are gonna. There's gonna be some. This is me getting you back for the trolling.
Good. So we. So send me the name, and I would actually get that registered and sent over. Then we'll charge Bruce some fee to change it back to RBean.
There you go. Next time you have it on, make sure it says Dr. RBean on it.
Yes. So there is a question here. Dan says, Dr. Bruce Patterson, how do I contact you regarding COVID nutrition? I research a lot of foods and their components to attack this. So
yeah, it's COVID. It's covidlonghaulers.com. You can register on there. If you have any questions, info@IncelDx.com. And someone from the clinical team will get back to you and kind of guide you through the process.
Got it. So let me do this. Couple of more questions from the Twitter side. There are a lot of questions. You are a very popular being. So there is a question here. Ang B says, does the vaccine spike protein stain blood like the long COVID protein, or do they disintegrate?
Yeah, we haven't seen any of the spikes in the blood. I haven't really seen any. I know it's been suggested that maybe causing the endothelial damage, but we're seeing this in the monocytes. But even that too, it's still very preliminary, and we will put out a report in a couple of weeks.
Got it.
Putting that all together.
Jonathan Loon says, from your paper, finding persistence of S1 in long-lived non-classical monocytes, can you shed some light on how the S1 protein is causing, I think we talked about it, high basal NFK beta activity and inflammation, and why is this protein not destroyed? Does this affect cytotoxic T cell activation?
Yeah, it's an interesting question. The NFKB role, and this is where the ivermectin comes into play, because it's known and it's been suggested in some of the studies that it inhibits the NFKB pathway, which regulates DNA synthesis and cytokine production. So possibly the spike protein might have an effect and working via the NFKB pathway and inhibiting apoptosis, which is why the discussions about ivermectin are very interesting and why we're seeing clinical benefit, because it's been suggested. I think there was a paper from Nature or a review article maybe about a month ago that's looked at the proposed mechanism of ivermectin and NFKB, and where it was inhibiting that, and which is what's causing the inhibition of apoptosis, which is kind of what we're sort of thinking why these patients are responding well to ivermectin. And also the ivermectin binding potentially to the spike proteins, having an affinity to that, as been proposed in many of the papers.
Got it. So with this, we have been talking for almost 2 hours now. Thank you so much for your time. There are tons of questions still on Twitter, and there are tons of questions over here as well. Maybe we can request you once again for about 3-4 months, and then you would grace us with 1 more or 2 more hours. But thank you so much for today.
Dr. Bean, it's always a pleasure. I think, I don't ever consider myself an expert in anything. I'm more of the guy in the back. I good of everyone in the room. I'm the background guy, and I appreciate you having me. And I really also I think what you're just such a gift to all of the medical community, doctors like myself, the general public, with your research and insights. And also, I think the ability to bring people together is pretty powerful. I mean, through you, I was able to get connected with so many other researchers, with Tess and Tina and Pierre and Paul, everyone else. So I'm also grateful for you including me, just at least being able to learn from all these other great clinicians and researchers, and along with yourself. So thank you very much for having me on, and also thank you for letting me troll all your guests, and having getting Bruce on and letting me troll him, and obviously he's taking the piss out of me right now. So I appreciate everything you're doing.
I'm actually grateful that you are here. Bruce is here. Osgood was here. Corey, Paul Marek, Chetty. There are so many. That increases the ambience of this area as well. So it is something that graces us as well. That is an honor for us too. So once again, thank you very much. I know it is late on the East Coast. Thank you for your time and insights, and more power to you. You are doing a great service.
Thanks, Dr. Bean. I appreciate it. Thank you very much.
And Thanks. Cool Beans, thank you very much. Tomorrow, I'll see you at 11 a.m. Pacific time with Dr. Pierre Corey. So please remember, it will not be 6 p.m. Instead, it would be 11 a.m. Pacific time with Dr. Pierre Corey. Thank you very much, and I'll see you tomorrow. Bye-bye.